Professor Landeiro.
Oh,
How are
Professor,
you?
nice to see you. It's a
Nice to
tremendous
see you
pleasure.
too.
How is going Mexico?
Very nice, very nice.
Very nice. A
Most
long
of the
time.
people are happy because of the football, you know.
The football,
Um,
yes, it's a tremendous party.
Yeah,
Mexico love football. Mexico love football. The
yeah.
Brazilian people love Mexico. Never forget the Guadalajara 1970.
Yes, yes, I agree.
1970.
Yes.
Yes. Everything okay with you? Are you going to Panama? The flight?
Uh, I don't know. Is there going to be a Congress or
Yes. The
yes?
flag meeting. Flag,
Ah, okay, okay.
flag meeting.
Maybe when is this going to be the Congress?
So many.
How many months? In July or
No,
August?
I believe in October.
October. Ah, okay, okay,
October.
good.
Let's have a time.
Okay, thank you.
And Mexico is going well in the World Cup. It's classified. It's classified.
Yes, yes.
Next game is not so hard, and probably
Hi.
is going more.
Hi, Mauricio, Igor, and Kiki.
Hi.
Good to see
Hello.
you.
I don't want to disturb this great
Hi.
discussion. So,
Hi,
have
Johnny.
fun. Ciao, Giuseppe.
Hi, Mauricio. How are you? Nice to see you.
Bye. Thank you. Thank you. Mhm.
Hello, good evening, everybody. How are you?
How are you,
Hi.
Keki?
Yeah, good to
Hi.
see you,
Kiki.
Kiki.
Oh, wonderful.
Hi,
Thank you.
Kaki.
Thank you. Thank
Hello,
you.
Kiki.
Hello, Kiki.
South
Our
America.
Spanish
What?
citizen. Spanish citizen. Spanish citizen. Kaki.
What time is it now? What time?
Oh,
What time is it in America, South America?
in South America now is 11 o'clock. 11 a.m. 11 a.m.
In the morning. Okay.
Yeah.
It's
11 a.m.
comfortable time.
Yeah, yes. Everything okay with you, Kaki?
Very good. Very beautiful
Very
time.
good.
Tonight I'm going to Athens. There's a conference on, there's a forum actually, an international forum on modern technology in Greece, in Athens.
Oh, good.
But it's a 2-day forum where we will be meeting some industry people for the AI and robotics integration.
Oh, perfect.
Yeah. Which is also partly going to be
Nice to see.
part of my talk today also.
Yeah. Oh,
Talking about
good.
the future of skull base.
It's always to see you. Always to see you.
Thank you. I hope
Always
you're
to
coming
see.
to Italy. I hope you're all coming to Italy, to Rimini,
Yeah.
in October.
Ah, sure. Himini is a
Yeah.
good time, eh?
Yeah.
I probably I am send a paper. I just finished.
Waiting for you.
By end of
Oh,
my
nice
paper,
to see you.
my papers are also
Nice to see you, Professor.
I'm going to Giovanni. I'm going to give a introductory talk on the whole panacea of complications for some time, and then I will submit some individual complications. So I'm
Just send my last complication. Is ICA aneurysm, traumatic ICA aneurysm after giant acoustic neuronoma surgery. But the patient survived very well.
Yeah.
Yes, I'm sure that.
I think sometimes we need to be lucky.
Very
Yeah.
nice.
Sometimes everything goes well and the patient doesn't wake up. And sometimes when everything goes like a mess and nothing happens to the patient.
Perfect.
You know, it is very paradoxical.
Yeah, sure.
Hey, Matt.
Hi, everyone.
Hey,
Hello.
Imad.
Hi, Mad.
Hello,
Good to
Imad.
see you. Long
Hi,
time.
Matt. Good to see you.
Nice to
Mauritius.
see you.
Imad the boss.
Luciano,
Igor,
Kiki.
Igor.
Hello.
how are you,
Igor.
Igor? Nice to see you, Igor.
Nice to see you, Landero.
Hi, Igor.
We have a Brazilian weather in France now. It's 40 degrees today.
4th degree,
40,
like a Brazilian summer,
like Rio summer. Yes.
Rio, in January.
Good to see
But
you.
now, Igor, we have a wonderful temperature here, maybe 15, 17, no more.
Oh,
Yeah, because
You
it
start
started the
getting
winter.
competing with Saudi Arabia and Dubai.
Uh,
You will come for vacation to Dubai rather than to stay in Paris or
in
Spain.
in the middle of the afternoon, we got 45 for some minutes yesterday.
Oh yeah, same
Oh,
like here.
oh. So we in Mumbai are better than. It looks we are a little better off.
Yeah.
I never
30.
forget, Imad, one day, maybe 2011 in Riyadh, and
Right.
we walked 11 o'clock on the morning to between the old streets in Riyadh together. I never forget this time.
Yeah.
Maybe already 45 degrees
It's always 45 in the summer, yeah. Standard.
standard.
I can see Dr. Abu Zub is the only one working today. He is in his cap and hat.
Somebody has to work.
Yeah.
Yes. Yes. No, but
We are
sometimes
sorry.
even if you are not operating, scrubs is a very convenient way to dress. Igor is wearing the scrubs. You are all wearing scrubs.
Oh, this is lab scrub.
It's a lab coat.
Yeah, yeah. I'm running workshop today.
So you are working too. Everyone's working. We are all working.
We past 3 o'clock, 2 minutes past 3 o'clock. Maybe Imad, we probably should
Hello.
do some introduction and then maybe we can start up with the program.
Well, I'll be very short. And well, first, thanks, Ramesh, for organizing this webinar. And you have been doing a great job for all these activities this year. And I think more to come. And welcome all of you. I hope all of you are healthy and with your family. And I'm looking forward for a very successful webinar to continue the momentum. I just want to say that Professor Benish has apologized. He has conflicting appointment. So I understand this is the first time he said, of course, he is an essential member of the group. That's what I want to say. Go ahead, Professor Ramesh.
Thank you, Imad, and welcome all. And it's great to meet up again, separated by vast distances and time, but it's so much happiness to meet up. But hopefully we will meet up in places in person. And last 2 months ago, we met up. Many of us were there for the Cordoba meeting, and we had a fabulous time. And Keke is reminiscing that memories, I suppose. And Mauricio was there.
Yes.
And Luciano. Anyway, so we would like to start with the first session of the program, and I'll ask Prof. Mastrodani to chair the session with me. We'll go for the first program. May want to start off, Luciano, and we can get the part.
Sure.
I think we can go ahead, please.
Okay, thanks, everybody. Good afternoon. Here in Italy is 4 o'clock. Then I would like to present the first speaker is Professor Igor Maldonado. His lecture is Anatomy Relevant to Anterolateral Surgical Approaches. Please, Professor Maldonado.
Thank you, Professor Mastronardi. I'm trying to share my screen. I need your authorization for that. Okay, let me just see if I can do it. Yeah, from my side. Sharing options.
Hello. Hello.
Let me just shoot for a share. Okay, so
Hello?
okay, now
Yeah, perfect.
try again, Igor.
Yes.
Hello?
Let's see. Do you see my screen?
Hello?
Yes, we can.
Yeah.
Perfect.
Thank you. So thank you, Professor Mastronardi. Thank you, Professor Nair. I'm very glad to see you all, and I welcome all the attendees. I think we'll enjoy the webinar. It's a great program today. As you know, it's impossible to detail the whole anatomy for anterolateral approaches in 15 minutes. So what I did today is a selection of topics that I think are important or fundamental for those approaches, and I will focus on more peripheral anatomy, pericranial tissues, and bony work, and some words on the dura anatomy at the end. I always mention the anatomical mental picture as something essential for any surgery. However, sometimes the learning curve may be somewhat hard when anatomy is complex. We are neurosurgeons, and the anatomy combines elements of different natures: nerves, arteries, bony accidents, dural folds. And moreover, we were all educated in a more classical anatomy, natural anatomical position, and then you have all the time to transpose it mentally to the OR. And there is one method that is considered as particularly efficient for developing this mental picture, which is, of course, cadaver dissection. So the plan of my lecture is very, very simple. We're going from superficial to the depth. Of course, starting with the pericranial soft tissues and try to build this mental picture. Once again, it's impossible to cover everything, so it's just a selection of relevant anatomical relationships. So the anatomy of the pericranial soft tissues, as you know, is made up of layers. There's something that, of course, interests us as neurosurgeons. Something that is very interesting is that these layers, they have topographical specificities. And one important landmark here is the superior temporal line. This is a structure that we'll know very well. When we are drawing our approaches, we are always palpating the superior temporal line. And actually above the superior temporal line, we found this strata as in any part of the body. 5 layers are described, so the skin, the subcutaneous tissues, then we have this epicranial aponeurosis, which is the gallia aponeurotica. Then we have again some subcutaneous tissue, loose connective tissues with the confers. It's some mobility, and then you have the pericranial and all those layers before the bone. But when we are below the superior temporal line, the situation is different. We have something like this with 3 different fascias that has been described. One is what is called the fascia temporoparietalis, or frontal or temporoparietal fascia, which is actually the continuation of the gallia aponeurotica. And then again, you have some connective tissues under it, which is favorizing mobility, and this has received the name of fascia innominata. And this is fascia innominata. This connective tissue is a key structure here because vessel and nerves will run external or internal to this structure. And then under the fascia innominata, we have this deep temporal fascia, which actually is the fascia of the temporalis muscle per se. So when we say fascia of the temporalis muscle, actually we're saying the deep temporal fascia, which itself has 2 different layers, a superficial layer and a deep layer that are attached to the external and inner part of the zygomatic arch. So below the superior temporal line, you have this organization, and the spaces are created, and you have a vessel and nerves that are running here. So you have three groups of vessels. First, one is the superior temporal vessels, the superior temporal artery and vein. The other is the middle temporal vessels, and the other the deep temporal vessels. The superior temporal artery and vein, the artery is, of course, as you know, the terminal branch of the external carotid artery, and this superficial temporal artery is running external to the fascia nominata. And the medial temporal artery, which is a branch of the first one, is the one that will perforate everything and will perforate the deep temporal fascia to contribute to the vascularization of the muscle. And then you have the deep temporal vessels, that will be the inner ones that will be running close to the bone, and actually are direct branches of the maxillary artery. And then we have something that we also interest us is that there are some specificities on the anatomical relationships between vessels and nerves here will be useful for us to preserve nerve branches. So it's the case, for example, of frontotemporal branches of the facial nerve. They are described as temporal branches, but they are frontotemporal in nature, and those branches are running very superficial, close to the skin, and reaching the fibers of the frontalis muscle and in the forehead. So this is an anatomy that has some, as I said, some interesting anatomical relationships, because you see here, you have the two main branches of this superficial temporal artery. You have the posterior parietal branch, and you have the anterior frontal branch. And a constant anatomical relationship here is that those frontotemporal branches of the facial nerve are consistently anterior to the anterior branch of the superficial temporal artery. So it's an important landmark because it is something that's easy to be palpated. And when you're dissecting, so you see you're reaching that region, and you know you're approaching those nerve branches, you're getting closer to them. And that's the reason why some authors have been called this region here as the dangerous triangle. Another thing is, of course, this famous fat pad, with in between the two layers of fascia of the temporalis muscle, so between the superficial and deep fascia of the deeper temporal fascia. And that's what allows us to deepen our dissection and then preserve these branches if you were at least 1.5 centimeters or 2 centimeters behind the orbital hem. So usually we describe two different ways of managing this. One is, of course, in getting into this interfacial space. The other one is get into the subfacial spaces, means that the deep layer can be, of course, elevated with the skin, and then you're sure you're protecting your branches. And another one, more classical one, is elevating everything, the temporal muscle with the skin. What about the sensory nerves? So sensory nerves are also very superficial, very tiny nerves. We see here the supraorbital and supratrochlear branches, which are branches from the ophthalmic division of the trigeminal nerve. You know, the ophthalmic nerve is the one that penetrates the superior orbital fissure and one in a very superior location into the orbit, and then will emerge this, will give this tiny branches here. The supraorbital branch is the one that will run inside the supraorbital notch. Sometimes it's a canal that can be opened if needed, for example, for pericranial dissection, if you think that pericranial is needed for skull-base reconstruction or treatment of frontal sinus openings. And then we have this bone landmarks. Of course, it's just a selection what I think is useful. A couple of sutures that will be important here. Of course, the coronal suture, and then frontosphenoidal, frontozygomatic, sphenoparietal, and the scamus suture, and some landmarks, the zygoma, the pre-auricular depression, that's usually we can palpate and start to understand where you are. And then you have the, of course, the piterium, with epithelium, it's just small parenthesis, pteron means wing. It comes from ancient Greek. It's a reference to the god Hermes, which is an ancient mythology god that was some kind of messengers of the gods that had two wings attached to the side of his head. And then this is central of many approaches in neurosurgery because the pteronal approaches is one of the most versatile approaches we have, and it is the confluence of four bones. So important anatomical relationships here. One is quite interesting is that you have just a rapid projection here of the branches of the middle meningeal artery, and the anterior branch of the middle meningeal artery, you always cross the pituitary. And then you have when you follow this sphenoparietal suture, you have a posterior extremity here and the anterior extremity here, which is also quite interesting to build our mental image, even though it's very rough landmarks. They're not very precise, but however, they are useful. If I can draw here just a projection of the cerebral lobes, will be something like that. And then you have here the temporal lobe, correct? And then you have the Steven fissure that will start somewhere there. And then you have here the parietal bone. And you know the lateral most point of the parietal bone is the union, which is more or less here. And we know that this lateral most point projects to the supramarginal gyrus. And then what about these extremities of the pituitarium, you know? See, if it is the supramarginal gyrus here, it means that you have the posterior extremity of the lateral sulcus, the anterior extremity is somewhere there, and then you have already some kind of rough location of the Steven fissure, and this posterior extremity of the pituitarium is the one that will be closer to the anterior Sylvian point. And the anterior extremity, even though it is not very precise, is the one that will tells you where the lacering of the sphenoid bone is arriving. So it's not mathematics, it's just how I build this mental image. I think these are useful landmarks. I thought there is another one that's also useful with what was called the Stephanion. So Stephanion is the crossing of this superior temporal line that we palpate all the time, and the coronal suture was here. And we know that this Stephanion is located 2 centimeters distant from the end of the inferior parietal sulcus. So it means that if you have the inferior parietal sulcus that are passing to the Stephanion, though now you know more or less where things are. So you know where the posterior extremity is, you know, you have a rough image where everything is. It's quite useful. So another important point is, of course, the keyhole. Keyhole is usually described as 5 to 6 millimeters posterior to the confluence of sutures here. So we are under this anterior extremity of the superior temporal line, and given a number of variants have been described. I'm not going to cover everything. So one is the Marquardt keyhole, which is simply the keyhole. It's the blowhole that can be placed to expose both anterior skull base and the orbit. So it's well positioned, and you have periorbit and dura at each side of this oblique strip of cortical bone. And then you have a more posterior variant, and also more superior, which is this sphenoparietal point. With this one, actually, you have this sort of triangle of a 3-point star, and then you have access to both anterior, middle, fossa, and the orbit. And then when we go to the craniotomy, often in pituitary approaches, that keyhole is the first borehole we place. And then we starting exposing and drilling the lesser sphenoid wing. And as we drill the sphenoid wing, we get closer and closer to the anterior clinoid process, which has different degrees of pneumatization, different parts have been described, the tip, the head, the body, the base. And then we are getting along important structures. I'll get to the end in 1 minute. One is, of course, the superior orbital fissure, and then the optic canal, a superior orbital fissure that then that is below that line we're running, line that is actually very oblique in direction. Sometimes we don't see that, but the general direction of this lesser sphenoid wing is roughly from medial to lateral, inferior to superior, and then it's why is like that? Because it is exactly the form that is correlating with the direction of the sphenoidal portion of the cesium fissure. So the general direction of cesium fissure is medial to lateral, with inferior to superior. So this is actually what we're doing. We're following this sphenoidal direction of the cesium fissure from the outside dural space. So and of course, when you arrive to the anterior clinoid process, then you're running over the lateral root that are attaching this lesser sphenoid wing to the sphenoid bone, which is the ruptus tract, which is nothing less than the lateral root that's attaching that wing to the bone. And then you finish with the medial root, which actually is the roof of the orbiter. So, Professor Mastroianni, I will stop here. This is a only basic lecture, but I prefer to respect time. So I hope it was useful for some basic construction of a mental image from soft tissues to bone. Thank you very much.
Thank you, Professor Maldonado, for this very exhaustive lecture. Yeah, it's my pleasure. You know, I am very interested in these anatomical details. We learn this, we teach this in our dissection courses anytime, because it's important for youngsters to know exactly what everything is, especially from superficial to the deep, as you did, as you very well explored. Many thanks for this very nice presentation. Thanks a lot.
Thank you.
Welcome. Some questions?
One of I have a questions. One of the more important questions about this region is related to an accident as a pneumatization of the clinoid process, calcification of the petoclinoidal ligaments, and the third clinoid, the medium clinoidal process with a ligament involved the carotid artery. That's one of the more important points, how to escape this when to do a surgery in this area.
Yeah, thank you, Professor Landero. It's an extremely important question. I think the probably best answer is, as neurosurgeons, we need to learn anatomy, but also learn the individual anatomy. That's the most important thing. When we go for a case, we need to learn the anatomy of the patient and spend a lot of time on CT scan, also not only MRI, and look for those things. Yeah.
Thanks, Igor. This was fantastic. I thought start off with this lecture explaining the anatomical correlation, which is exactly what we would want everybody to know. So thanks for this talk. Maybe, Luciano, we can go for the next one in that case.
Yeah. Thanks a lot again, Professor Maldonado.
Thank you.
My pleasure to introduce Professor Aib Cherian.
I think Aib is joining soon, so maybe we'll wait for him. Maybe we could
go on with Maurizio.
Yes.
So my pleasure now to introduce Professor Maurizio Angeli. He's a friend of mine, of course. His talk is about the endoscopy versus open surgical approach to the cervical craniovertebral junction and upper cervical spine. Maurizio, please.
Okay. I try to Can you see the
Yes,
image?
we can. Yes.
Okay.
Yes, everything okay?
Okay. Thank you to this to Yana, this big family that give as we saw with Igor, a great insight on anatomy. The anatomy is essential in our job, even if we have the navigation, robots, AI, and whatsoever. In our life, mentor as important. For Luciano, if I remember, the mentor was Fukushima. For me, Samba. And one that really impacted on my future practice was Pernesky. But not because the KO, the supraorbital approach, okay, but because he gave me the philosophy of minimal invasiveness. Minimal invasiveness, I applied his philosophy even during scoliosis or even during a terminal approach, because the philosophy of minimal invasiveness is the respect of the plane. And this is a consequence of the perfect knowledge of the anatomy. And I'm proud that I reviewed my curriculum a few days ago, and I found this final letter that Pernesky gave to me, in which at the end he said, Dr. Maurizio Angeli came to us as a visitor and leave us as a friend. And this is a good insight that I want to share with you. The craniovertebral junction is just behind the rhinopharyngeal mucosa. So we have really a direct highway to the lower clivus, upper mid-lower clivus, up to C2, just through the nose. And as you see here, we can reach the most superficial anatomical lesion, odontoid, chordoma, and deep up to the brainstem, just with a simple incision, just with an incision on the rhinopharyngeal mucosa and drilling the bone, and we are in the brainstem. This is the eloquent anatomy. In the lower part, we can arrive up to the condyle, up to the lower cranial nerve, and up to the, with the extended the transtubercular approach, up to the third ventricle. So this is really an highway that we have to consider during our selection. There are many options, but this is one option, really minimal invasive. Talking about anatomy, anatomy is always the same. These three boxes looks different, but they are identical. They are just rotated. So we have to keep in mind that even if something seems difficult, with the application study, and this is the example of the anterior cranial fossa seen by above and by below, looks completely different, but it's the same. So this is for a young colleague that with follow the mentor and with the few few time of application, everything is possible. This slide, I like this slide because is what we saw, what we said. The same region reached from posterior or from anterior. And the definition of far lateral approach and far medial approach to the foramen magnum and the upper craniovertebral junction, for me, is the perfect definition on how the same region can reach it by different ways, but with the almost same results. So we have a spectrum, an armamentarium, a selection of options that we can apply patient by patient. Let's go with some emblematic case. These are two similar cases of foramen magnum meningioma. But as I will show you with two different approach, and I will show why. In the first case, this case, we selected the far lateral approach, the HEROS far lateral approach. Two concepts to be stressed. We selected this because one of the rule is try to find the best corridor that allow to reach you the lesion without violating too many anatomical structure and in safety. In this case, because the basilar artery and the brain was displaced like a fuse, the far lateral approach seems the correct solution. The second is that even millimeters of exposure can make the difference. You see, in this case, the clip is almost against the bone, and you see during this pica aneurysm the nerves and all structure, the corridor was very tiny. So if you drill a few millimeters more, that's give you the perfect corridor in safety. So the accurate preparation is one of the key of the success. In this in the other case, we selected the extended anterior endoscopic endonasal transclavial approach. Why? Because in this case, one or both the vertebral artery were inglobated in the tumor. So from posterior, maybe one of the vertebral artery could be at risk of rupture. So the anterior endoscopic approach maybe was the best solution because following the 4D of Amefti rule, we reach the tumor straight forward and we reach at the beginning the base of implant. So the vascularization was easier and we arrive to the most eloquent part of the tumor at the end of the approach, when the brainstem and the vertebral artery start to be decompressed, so we can work in safety. So you see how important is to have different solution. Starting from outside layer to the deeper layer, another disease that can be approached through the endoscopic endonasal approach is for example, the odontoid dislocation in case of rheumatoid arthritis. This patient has a symptom that quite strange, that were drop attack when she rotated the head. Why? Because the dents compressed alternatively the vertebral artery. And in this case, with the anterior approach, we have the possibility to decompress the brainstem, remove the disease, and respecting the anterior C1 arch and all the axial ligament, transverse ligament, because we see this ligament at the end of the procedure, we were able to decompress with not too much interfere with the stability of the spine, a sort of dynamic stabilization. And you see how the vertebral artery was decompressed and And in this specific case, you see here is the vertebral artery is compressed, now is completely decompressed, and even the brainstem is completely decompressed. In some cases, if there is arthrosis of the facet, it's not necessary to make this sort of anterior C1, C2 fixation. But in this case, in order to avoid the posterior occipital cervical fixation that limit too much the movement, we can even consolidate C1 and C2 through the screw that can be inserted by the nose. And important, every time is essential to reconstruct the plane layer by layer. Whenever is possible, we close the bone and even the pharyngeal mucosa, because the pharyngeal mucosa heals very fast. So in 2-3 days, the mucosal layer is completely restored, and this could prevent the CSF leak. They still remain a big problem in this approach. And you see now at maybe 3-4 years from the operation, the patient have a completely movement without any restriction and stability of the spine. So this is, of course, some extreme cases, not a rule, but to have an idea on how we can address disease respecting the anatomical layer is important. In this other case, we make a combination. This is why open and endoscopic approach are not competitor. They can integrate each other. This was a pseudoarthrosis cases of a C2 fracture. And what is the normal rule that orthopedic colleague apply in the pseudoarthrosis? They clean the fibrosis process, as you can see here, and up to healthy bone, then approximate compression and fixation. I try to translate this concept even in C2 pseudoarthrosis case. And in this case, so there was a usual anterior screwing and open, like you see here, supplemented by this cleaning of the bone gap in order to have, this is from the view endoscopic from the neck, in order to follow the progression of the screw exactly, you see here, the progression of the screw through the two bony stumps and verify that the compression of the two bone fragments approximate together. And then fill the gap with the iliac crest bone and the bone marrow in order to enhance the healing of the fracture. And this can be done by the endoscopic approach, and in order to guarantee a better healing with, of course, a longer procedure. But if it's acceptable and the patient is in good condition, in this case, we restore the normal, healthy condition as it was at the beginning, before the fracture. This is another option. This is a synovial cyst, C2 synovial cyst. Of course, can be operated from a posterior approach, but in this case was quite anterior and was monolateral. So I approached this patient, this is many options, I approached this patient through the nose endoscopically, and this is the approach in the postoperative MRI. And you see, because it is straightforward to the lesion. This is the navigation that give us the track, and the patient, the lesion was approached from anterior, so we reached the lesion before the eloquent structure and addressed the disease in a longer but minimally invasive way. In this way, in this slide, postoperative, you see the hole in the C1 without completely destroyed the anterior arch of C1 and the upper up to C2 just on the line on the right. This is another case that we can skip. Finally, the deepest anatomical structure we can reach by this approach is the brainstem. In this case, because the arthrography show us that the only safe entry zone was from anterior, we selected the anterior endoscopic approach, and you see the straightforward approach to the brainstem without interfering with the many anatomical structure. It was a little bit, I don't know, longer than the retrosigmoid or posterior, but the lesion was right there. And here, important is the preoperative planning, because at the beginning was not so clear the entry zone. But we see here that the lesion is just at the vertebro-basilar junction on the right side. And so we see the vertebro-basilar junction site right there. So with the stimulation, aeronavigation, and knowing the anatomical position, we can reach the lesion in safety. So in conclusion, there are not rule or suggestion. One rule, general rule that Pernesky always stressed was that in the approach we do not touch the brain. Almefti say drill the bone and take the brain alone, and the brain must be respected even if the approach could be a little bit longer. Endoscopy and microsurgery are not competitors, and sometimes the multidisciplinarity give us some expertise that combined can extend the bar, can rise up the bar. And I'm a fan of the history of medicine, and we seems that they discover all the stuff, but the philosophy is always the same, and someone already think what we supposed to discover. This is a sentence by Cocker just 1 century ago, Nobel Prize in Medicine, that is the exactly essence of the minimal invasiveness. Approach should be as large as necessary and as small as possible. And this is perfect the meaning of the minimal invasive approach. Thank you for the time.
Thank you, Maurizio. And congratulations for your presentation. If someone has questions for Maurizio, please. So, Imad, please, Imad.
Yes, a wonderful presentation, Mauricio. So I like it very much, and I like endoscopy through the nose. What is your decision-making criteria to decide in some of the cases that you have to go transorally and not transnasally?
Transorally, when there are big chordoma extended up to clivus C1, but more on C2 or C2, C3. That is impossible to reach from the nose. And whenever it's possible, I do not cut the soft palate, even from the oral, but use the endoscope and tilt up but use the endoscope to reach the upper part, because most of my complications were due to the infection from the mouth, from the cutting the soft palate, even with our maxillofacial surgeon. So the combination with open and endoscopy, even in transoral approach, could help in reducing the complication in transoral. But whenever it's possible, I prefer the transnasal.
And for the odontoid pathology rather than tumors?
No, the odontoid is easily reached because odontoid is always up to the C1 arch, and the C1 arch is easily reached from the nose. And if you cut only the displaced odontoid tip and leave part of the body, you can even fix with the screw in order to preserve the stability and avoid the occipitovertebral fixation that is always a mess, especially in young people that has limited range of movement, rigid neck, some instability of the lower cervical spine. So if we can avoid the occipital cervical fixation, is always good.
Thank you.
Maurizio,
Maurice?
may I ask you a question probably for the participants? It's important to know. I saw that you approach many cases intradurally, and this is not very well accepted everywhere because there are some complications, of course. And how do you suggest about these possible complications? There are some special way to close the dura, way to avoiding the complications, these infections. It could be sometimes lethal.
You are right, Luciano. The approach in the essence is very straightforward, and really you do not interfere with the girl. The big problem still is the CSF leak. CSF leak is we use the flap, fat. In the case of the cavernoma, we also use the cranioplasty to fill the gap of the bone. But still is a problem. The suggestion is always the same. Use some fat like champagne cap, like in the posterior fossa. If you put the fat deep in the dura, acting as a champagne cap, fill the gap, and always use, whenever it's possible, autologous tissue and vascularized tissue. This is something that I found and is essential that the tissue plans heal faster. If the scar, the mucosa heal in 3-4 days, that's good. Even if there is, it's like in normal craniotomy. If there is CSF, but under the skin, you can live. And this is the secret. But still, yes, in the literature, they say, no, with the vascular flap, with the new technique, the H technique of close the dura, but still CSF leak is important. This depends on the best working angle and young patient that cannot stay too long in the ICU. That's even a big problem. Staying in the ICU more than 2 or 3 days could be a mess.
So selection of patients is important.
Absolutely.
May I also make a comment, Luciano,
Sure.
if that's okay?
Please, Ramesh.
This fantastic set of cases, Mauricio. It's impressed by the advanced endoscopy work, including the fixation, because you often wonder when you put in metal works from the front and then either through the nasopharyngeal or oral cavity, there's a concern of whether this is going to be a problem with the hard work and metal works in place. But obviously, clearly, you have done it and successfully, which nobody can really argue with. And also, when the other option is to do a separate operation through the back and then fix it, which may be preferable to some people. But I guess you will not you will not think about a second stage operation if you can fix it from the front. Is that right?
Yes, of course. Yes.
Yeah.
And of course, in in a course, and we always present the extreme case or the good case, naive case, something that is you are proud of it. But this is not the rule.
No, agreed.
We use the C1, C2 fixation, the transolar, all the far lateral, the classic retrosigmoid that is always the best. So in this in the courses, just to give an idea that something is possible, but it's not the rule.
Okay, thank you. One more thing, if I have time, just the case, the cavernome, again, I think that's the same rule, because this was I would say many would say that why take an anterior approach in front of the brainstem, where you have the vertebral, the basilar artery and the perforators around it. But equally, I think if for me that probably was the right approach compared to some far lateral approach to, or a petrosectomy approach to reach the brainstem, because it is right in line with your endoscopy approach. Recently, we had similar discussion, as Prof. Mastroianni would remember, about a cavernome in the midbrain where in a big operation where an orbitozygomatic approach was used. But I think in selected cases, this case was probably an ideal for such an approach. I agree with that view.
Thank you. That's right, because from posterior you have to displace and not to have the right, and the pyramid tract was displaced laterally. From anterior, you skip, overcome all this and came from anterior. But as I said, this is quite a simple, a unique case, not the rule. Because if the lesion was a little bit more anterior or posterolateral, the best approach was, of course, retrosigmoid.
Thank you. Shall we just move on then? In that case, Luciana, shall we move on to the next? I think Prof. Aipcharian is here.
Aipcharian is here?
Yes.
Joined us?
Yes, he's on the panel.
Well, very good. It's my pleasure now to introduce the last speaker of this session, Professor Aipcharian from India. Its presentation is the unarticulating endoscope for minimally invasive surgery. Please, Aip.
Thank you, guys. Thank you so much. We are in Greece at the beach, and
fantastic.
When that's I was having some problems connecting, but I guess thanks to Ramesh, everything has been sorted now. Can you see my presentation?
Yes.
Yes.
Okay. So with regards to the articulating endoscope, I'll show you some pictures of what we've done. But more than that, I would like to talk about the general anatomy and what we can achieve with the articulating. I mean, first thing first, I think we have a very young crowd as well as a very seasoned crowd. So before the endoscopy, which is very highly selective, especially the articulating endoscope page, where we get a view which is extremely selective, I'd like to show some cases where we went on from normal invasive to minimally invasive, and then how we are going with very small, and then maybe I'll dwell on the future as well. So this is a case which is a petroclival cystic solid lesion. So you can see we are, as usual, we are doing a very small temporal craniotomy, frontotemporal, very small frontotemporal craniotomy. And then we go ahead and peel off from the middle fossa. And once we peel off from the middle fossa, we do a very, very limited petrosal. So we can calculate with when we superimpose what is required, what is the craniotomy required. So we work with something called Medharanya now. This means that it's a software called MedDigital, like Medivis, but way better and can be integrated to the exoscope. So once we do that, at this point of time, we didn't have that, but just wanted to show you how we can make in a small petrosectomy, just enough. We can see the V3 there, and then we are going to cut the superior petrosal sinus. I don't clip it because it takes a lot of space. So earlier I used to clip it, now I don't. I bipolar and cut it. Most of the time that's required. That is only what is needed. Sometimes you need to take a stitch. I use the stitch to retract. And now I am cutting towards the Meckel's cave. And I'm going to be in a window which is just between the 5th and the 7th now. I've seen Luciano showing these kind of cases. What we are doing here is, this is a few years back, and I wanted to show you what we were doing at that time. So this is still minimally invasive. For most petroclival, now we do a very simple, small subtemporal craniotomy, 2 to 2.5 centimeter craniotomy, and do a petrosectomy. If Vladimir was here, he used to hate the petrosectomy, so he would always get these from the supra-infra approach. But I love the petrosectomy. But I realized that you don't need to do an entire petrosectomy for all cases. That's the medial edge of the tendon. You can see the 4th nerve there. And you are going to be, once you release that, you are going to be what I'm retracting is the retrogastrian 5th nerve. That's the 7th nerve. So you are going to be just in between this corridor, between the 7th and the 5th. That is all. So that is the true petroclival corridor, I must say. I mean, you take off this bone, you open the Meckel's cave, you open the tent, and you're maximizing that entire approach, which would have been a very, very thin corridor. You're now getting an entire huge corridor. So we first take off the cystic part of it, the solid part of it, and the cystic part of it. Cystic tumors, as you know, they're very easy to decompress and all that. But once you start pulling, they generally don't come out very well. And if they come out, there's always shared vascularity. And this shared vascularity will cause problems to the cranial nerves, especially in cystic schwannomas. If you go ahead and try to pull it instead of total decompression, you will end up taking off the 8th nerves or the 7th nerves vascular supply sometimes. So it's total internal decompression is very important. So you go ahead and completely decompress from inside. So you can see that that's the retrogastrian 5th nerve into the brainstem. That's the 7th nerve. That's the pons there. And very soon you will see the basilar also. And it is under very high zoom. The tent is cut and retracted. Now you can see this movement of the exoscope. Well, my hands are still on the field. So my hands are still on the field, and this is a endoscope holder, robotic endoscope holder, holding a 10 millimeter 4K endoscope along with the exoscope, and I'm seeing on a split screen. And now the same basilar and the perforator I can see on my exoscope screen also. Once I identify that with the endoscope, then that's a 30-degree endoscope. So I can see now that is the retrogastrian 5th. That would have been the pons. And here is the 7th now. So this is how we started going minimally invasive. Now let me show you a cavernous sinus, which we have done. So this is a solid cavernous sinus tumor. The cranial nerve. So you can see that there is lateral to the cranial nerves, medial to the cranial nerves. The tumor, both lateral and medial. So we cut the orbitomeningeal band. This is something that we described maybe by 2014 or 2015, the bloodless transcavernous technique. So that is the third nerve. And you can see the magnification on this. That is the anterior clinoid process. And we using a 0.75 millimeter drill. That's a 1 millimeter suction and a point. So that's the anterior clinoid process taken out. That is the third nerve. So that is a fourth nerve. That is V1. So I'm going between the fourth nerve and the V1. That is a Parkinson's triangle, opening it up from all the way. That's the sixth nerve will be there, that white thing. See, we fasten up this. I mean, this is really fast. So we go ahead, take out lateral to the carotid and medial to the carotid. We take out all the tumor, get it empty completely. And that's how these tumors are taken out. So no bipolaring and operation under very, very high magnification. This is extremely important. Well, this is for skull base. Any skull base lesion, this is also a large skull base cavernous segment aneurysm. It's whatever you learn, minimally invasive or large craniotomies. One thing you always need in these kind of lesions is the ability to have a very good bypass. And if you learn to do this bypass, then most of these lesions you can go in with much less, already know that. I mean, I'm not the type who on insurance as Ramesh and all my friends. No, I mean, I wouldn't mind going without any insurance, but for the patient, it's always better that if many times I remember with my ENT colleague Vinod Felix, we go into very difficult places, and sometimes we've had cases where we've had carotid injuries, and at that point of time, of course, we'll have to rush into the endovascular suite, and sometimes needs to occlude. But then you have a bypass, then it is much easier. So even in minimally invasive approach, if you are doing something with your endoscope, or if you are opening into the cavernous sinus, especially when the patient is radiated, it's always, you have to expect a carotid injury or some rent in the carotid. Of course, most of the rents you can close off with just muscle. Just muscle and a layer of Serge cell, you can do that, but then you should know how to do the bypass. Now, this is something all my friends are very familiar with. This is the schematic of the ICA segments that we described many, many years back. I remember drawing these pictures with all my friends for many, many years, starting from 2011, 2012 onwards. So almost 14 years I've been drawing. Now, this has been accepted as one of the three main classifications of the extradural internal carotid artery. You can read about this in many, many papers, textbooks now. It has been our work with first with the WFNS anatomy with Vladimir, and then later on with IANA. Now, these are with the endoscope. These are some of the interesting cases which we wanted to do. So this is this here. It's a rather large, not very large, but a rather large, oddly shaped tumor. Here, the thing is, people may, I've seen a lot of guys telling me that, oh, after I've done the resection, I could see the third ventricle and all that. So that is completely wrong. So if you see the third ventricle, that means your surgery is not correct. I mean, many may disagree with me, but then even in this kind of a tumor, the diaphragm is completely intact. And if you take off the diaphragm, remember what comes through the diaphragm, it is the stalk. and it is the pituitary that is connected to the stalk. If you take off the diaphragm, if you go past the diaphragm, that means you have injured the stalk. There's no question about it. So unless somebody is already made, I mean, this also we get it sometimes. So we get somebody who's gone through the diaphragm and then, the tumor is all over. For that, we now prefer the mosaic approach, which is a supra-brow approach, transorbital, and an endonasal combined. But this is what I wanted to show you. Here, now you see when you're dissecting this tumor off, at the end, see the diaphragm. It's completely intact. Once the tumors are all taken out, you have this diaphragm bulging into the seam, and you will see how finally this looks. This is a brainstem tumor. Here, what you should notice is that the basilar is completely on the right side. So if you have to go in from an endonasal route, the tumors, you see there's thin brainstem all around. And the tumor is, the only way you can approach this tumor is from front. I would have loved the petrosal approach here, but then the petrosal approach will not get this part of the tumor. It's very difficult. You'll have to do retractions and all that. So since the basilar is displaced to the left, the only thing you have to displace here is the sixth nerve the basilar is displaced to the right. You have to displace the sixth nerve to the left. How do you do that? You go transclavial, then you go into the Gulfar segment, you open up the Gulfar segment, and after that you take off the PCP, you open up the Gulfar segment, you cut the posterior petroclinoidal and the petrosphenoidal ligament. I believe this is one of the few times this has been demonstrated, the cutting of these ligaments. And then you can take out these tumors. That is a clivus. There, that is a sella. If you drill in these directions, you can take the posterior clinoid off. So you are taking the sella dura. Now you can drilling the sella dura. And now drilling towards the posterior clinoid process. What we do is we displace the sella dura completely up. And then now we are opening. Once we are opening, you will see that is the word, and that is the very vascular clival dura. So once you do that, you can see the sixth nerve, the petrosphenoidal, that is a Gruber's ligament, and the posterior petroclinoid is cut there. And then once you do that, you can see the basilar perforator there. You can see the left vertebral artery, that's the basilar artery completely displaced to the left side. And that's how the tumor's taken. This patient came to us on a wheelchair, walking now, and these are some of the things which help us. This is an endoscope holding robot, something we designed, and it's my ENT colleague there. That's pica aneurysm done through the endoscopic route. I really wouldn't advise now, that we have done these cases. The doing it is not an issue actually, but reconstruction is, even with a good head flap, and even by positioning the aneurysm in a way that, you can see how I'm going to put the clip now. This is all done 4 to 5 years back. So I'm displacing the 12th nerve rootlets. So what I want to tell the youngsters is that they try and explore a lot of new things. They must understand it has been done many times. So you see, I am putting the clip that way so that it doesn't jut out of the defect and I have problem putting in the flap, or the flap doesn't see. So now this clip is parallel to the vessel. That's a vertebral artery. That's the 12th nerve rootlets. And that is where is clipped. So it's not jetting out. I can still do a reconstruction, but the problem is even with this reconstruction, we do a tri-layer deep reconstruction. We know this pretty good at that, but then even with that, you have multiple problems, and I have shifted back to clipping the pica aneurysms the way I was clipping it before. I never had much problems, but ideally cranial nerves should not be passed when you have to clip, and pica is a good example where you have to go through cranial nerves. So not a problem. You can clip most of the picas from behind. We tried the anterior way, and I would still recommend the posterior way. And this is some of the things that we've done in the past. Now we have an IMRI, single room IMRI. You will see more about it later. We will be established. We have the much better exoscope. It's an intuitive exoscope. We had the intra-op CT before on rails. Now we have a single room, same room IMRI, and it's an open MRI so that you can shift. You can get the patient on the table, no transfer. The table just, it's an FRP table, sweeps into the MRI. We also have the ultrasound along with that. The ultrasound images are with AI. It is linked to the MRI. It looks like an MRI. And then you can see them on your virtual reality or your VR glasses with the exoscope. This is the Sanma Yoko exoscope, which I designed and named after my daughter, whose godmother is Professor Kato. So it is named after Yoko Kato, Professor Yoko Kato. This is the robotic exoscope making its debut in Dubai. And this is what I was talking about. Now, this is a very, very small craniotomy. Okay, very small craniotomy. And you see, I have put in an endoscope here. And with this endoscope, this is an endoscope which is modified from a laryngoscope. Now, the laryngoscope the tip moves up and down, and you rotate it, you'll get all the side views. And this is just one of the views. I mean, being in Greece, I haven't got the entire video. I've been asking people to send it to me, but this view, you see, that's superior cerebellar artery. That's the third nerve. You can see the P1 there, the P1 there. These are the basilar perforators. That's the vertebrals there. The sixth nerve could also be seen there. And that was the fifth and the seventh there. I could see the entire lesion. This is a 3 centimeter craniotomy, okay, in the subtemporal region. We've gone transcavernous. We've gone in through the fourth and V1 window. And you can see with that scope, I mean, people told me, even the team told me it was crazy to attempt such a massive epidermoid with that. But then we could take out everything. Okay, well, with epidermoids, you cannot say everything, nearly everything, okay, till you can see the arachnoid membranes. So with a very small approach, okay, something that the patient went home in 3 days. So this is the future. And now we're getting it in 3D. So it's a 3D bendable endoscope. Already the endo eye from Olympus is a 10 millimeter bendable 3D endoscope. But then that's a bit too large for us. So we're trying to get 6 millimeter scope. And you can use it instead of an exoscope. And this is the view that you will get. And this is the petrous apex lateral to the ICA. Okay, this is medial to the Meckel scale and lateral to the ICA. So this is the petrous apex that you get, and with the reciprocating kind of drill, you can take out this entire petrous apex, and you can use it for many different lesions. This is the intra-op MRI that we are getting. So by Jan, when all of you guys come, you will see this intra-op MRI, exoscope, everything in place. A lot of things I cannot share. Earlier I used to, but then we have NDAs signed in place. So I cannot, this is the hypervision that we wrote about. I started talking about this from almost 10 years back. This is open MR. And of course, these are some of the other things that we are doing. Thank you very much. So it's a hi from Greece, and as all of you would know, for me, my life is such that neurosurgery is just a part of it, and it's not an all-encompassing neurosurgery. I love my life and everybody. So this is Yuha. We miss him so much. He's been with us for 1 year in Biratnagar, learned a lot from him. And so this is what it is. So it's great to see all of my friends, all of you. Thank you so much. God bless.
Thank you. Thank you, Aip, for this astonishing presentation. Congratulations for the high-level technology you presented. It's for sure, as you said before, is the future. We have to go in this direction, everyone, for any kind of surgery we do, but the future is for sure in the direction you drawn before. Thanks a lot. Some comments by the other faculties or someone?
Igor wants to say something. Igor.
Yeah, thank you. Thank you, Ipe. It's nice to see you. You are always ahead of time and also innovative. But I must ask you something, regarding vascular neurosurgery and clipping under endoscope. Are we witnessing the future of neurosurgery, or we are reinventing a solution for something that was already addressed? I think it's a central question for the young generation.
In all my life, I have been clipping. And by the way, first thing first, I must acknowledge Igor. Igor has been a very dear friend for so many years. And Igor was central to that paper on hypervision. He's part of that chapter, actually. So Igor helped us with that. And then when we are now making it, I'm sure he will be proud of this when he comes and sees what we've done now. So now, if you ask me, clipping, I have clipped everything, anything that I cannot clip, I bypass. So this is, I've been telling interventional radiologists for all this time, but the more I see it, I think clipping is dying. There's no question about it. It is not because clipping is an inferior art. It is because the young generation just doesn't have the heart to stay 10 years to learn an art which is on paper as equal as something they can learn in 3 months. And we cannot blame them, because if you want to clip posterior circulation aneurysms, you need to be with the master for 10 years. It is not easy. And even then, you have a lot of heartbreaks. You still have a lot of problems. You can talk about the scenario in low and lesser developed countries that interventions are not available and flow diverters are not available, all that. You can talk about the 1/4, 25% of patients getting recurrence, but coiling and endovascular therapy is moving forward. And while clipping is, unfortunately, it is not. I've tried my level best to advance it. I mean, God knows I can cross my heart and say that, we've tried to get anastomosis to a very high level. We've tried to clip all those unclippable aneurysms. We've tried to design new things. But at this point of time, I'm not somebody to give it up, but then this point of time, I must say, and I don't know how many of you will agree with me, we're all old dogs, okay? And clipping is generally, it will be there for a niche population who will do it. And when coiling is a problem, but I don't know how many of us will survive into the next generation. How many of these youngsters will take up and be as good as we are when it comes to, having a failed aneurysm to be clipped. And this remains to be a very interesting question.
Hi, can I just make one comment? I love the presentation. The technology is fantastic, and I think it's coming. But from a sheer cost perspective, you know, a clip costs you $500, and an Angio suite costs you $4 million. I mean, look at countries that just don't have the financial capacity to provide for a population of a few 100 million people. So I, without doubt, think we need to continue to teach anatomy and surgical approaches for open access to vasculature at the highest level, because for the next 25 years, it's not going to go away. And as much as I love the idea that most things can be done from the inside equally well, from a cost perspective, that is just not the case. You know, cost is running out of control in most countries. And that's why I think we have a vital role to play to maintain that skill set.
Yeah, let me answer that also, Ek. Good to see you. And see, the thing is, what we are designing, for example, the exoscope that we are designing, it is way better than Esculap's upcoming digital surgical cockpit. I know for that because I am the lead design for that, and I have been the lead design for this exoscope. It's an intuitive exoscope where we have 3D, 4K, everything coming into. So if it is so good that if you take a suction and you touch, and if you touch something which you don't identify, it will segment it and show you all the, and it will even tell you that this is the carotids, this segment, fourth nerve is going to be here, sixth nerve is going to be.
All right. Very good. Thank you. Professor Broad,
so that is what is coming into.
Oh, sorry.
That's
network
what it
is not very good over there.
Yeah, no problem. Yeah. Can you hear? Can you hear me?
Yeah. I think the network was a bit slow, so you broke in between, so didn't hear it completely.
Yeah, just only one thing. The IMRIS Brain Suite plus Brain Lab Navigation is 33 million. While the suite that we are making, it has the intraop MRI, integrated navigation, AI board, so that machine learning, machine vision, exoscope, navigation, neurophysiology, integrated neurophysiology, navigated neurophysiology, ultrasound, everything that 3 million. This is one and the cost. The music we have been making a lot. So it's a big war. It's not easy to take on these giants, but they've been been giving money to the conferences. They've been giving money to all the federations. So they are deeper, but it's like, know that more than I've been working in this countries. I've worked in for 14 years, and right in India, which if it is right now, it's good faith, but it was not all the same. So I understand and I'm aware of this. So we are trying to bring the cost down for even the most cutting edge technology.
Good. Professor Broad, do you have a question?
No, I don't think anybody has any other thing to
Professor
say.
Broggi has raised his hand, I think, before.
Oh, did he?
Yeah.
Giovanni?
Professor Broad, yeah, before.
May I?
Yeah, you can, of course.
Okay. Thank you so much for changing the the timing. Let's see if I can.
I think Giovanni wants to go next in the next session.
My presentation. Did you see my presentation?
No, we can't.
No.
Okay. We'll go on to Imad. Are you there? We can start off the next session in that case.
Well, we'll proceed with Professor Broggi as a first speaker or as a co-chair.
If it's okay with the Prof. Lantiero, we can start off with Giovanni, and then Prof. Lantiero can proceed after that.
Giovanni,
you see my
go
presentation?
ahead with your presentation. Yeah, go ahead.
Yeah.
Okay, so thank you for giving me this opportunity. In this presentation, I would like not to show I'm as good I am, but as good is this approach that is most important for the young people. So first of all,
are you sharing your talk, Giovanni? I can't see it.
You cannot see?
No, we cannot see.
Please share.
Yeah, I was sharing my presentation. Did you see my presentation?
Not yet.
Not yet.
No, not yet. Not yet.
Okay, let's see if I can. I try to divide. Okay. Yes.
Are you trying to share?
Yeah, I tried to share it.
It's not coming up.
No password. It's not coming out.
No.
You want us to give you time so we can proceed?
Yes, sure. Go ahead, please.
Okay. Well, I'd like to invite my friend, Professor Landero, has the vast experience for having a magnum pathology, especially tumors. And he's going to talk about subtonsillar approach, indication, and challenges. Professor Landero?
Yes. Did you see my presentation?
Not yet.
Oh, sure.
If you can share your presentation.
Let's see.
Yeah, I think it's coming up.
Yes, it's on. Yeah, go ahead.
It's okay?
Yeah, put it in presentation mode. It's already, yeah.
Oh, thank you. It's a wonderful time to see all my friends here. And my focus is about the subtonsillar approaches, indication, and surgical nuances to foramen magnum tumors. I want to talk, my focus is about the meningiomas, is the most common tumors in the foramen magnum. I have a lot of cases, but the foramen magnum meningioma is the more exciting chapter in this area of the foramen magnum. As you can see here, my series from 2004 to 2026, and we had the 37 meningiomas of the foramen magnum. All of us must remember the key points of the foramen magnum surgeries, and I want always remember the vertebral artery, V2, V3, and V4 is a guide for us to dissect and to remove the tumor, the position the tumor in relation to the dentate ligaments, and the C0, C1, and C2 joints. It's more important to remember that one of the more important areas in the foramen magnum is placed laterally, because laterally we have the foramen jugular with the glomus jugular and the jugular vein, and laterally the vertebral artery. Inside the foramen magnum, the amygdala, the brainstem, and the lower cranial nerves. It's always remember two professors in this area, Professor Bernard George, who classified the tumor according to the position in relation to the vertebral artery. Above the vertebral artery means tumor invading the cranial fossa, and below the vertebral artery, tumor is placed more into the cervical canal, a tumor anterior to dentate ligament, to posterior to dentate ligament, require a different approach, and this classification help us enormously to treat the foramen magnum. The history of the foramen magnum surgery changed after classification of Bruno and George. I want to remember Professor Robert Harris, because Professor Harris in 90s do the very similar approach to treat vascular aneurysm from pica and from vertebral artery. He did a posterolateral approach. He started from all the middle inside, like a head, extended the head sigmoid approach and closer to the midline and approach to many aneurysms of this area. His peering tips and tricks is on the IANA book, and I always should remember the last paragraph. The last paragraph is command my life of surgery. My life of surgery is to preserve the function, even if I leave a small part of the tumor according to the circumstance. But this is my philosophy. This philosophy came from Professor Sami, from a lot of friends who live in the last time. The traditional approach for this area is the posterolateral approach. And in the posterolateral approach, if you go far, you can dissect the vertebral artery in the arch of C1. You can dissect the vertebral artery between transverse foramen C1 and C2, and you have a completely control, and you can go anteriorly until to remove, sometimes it's necessary, one adductoid plus. But I used to put the patient in prone position, not always. Monitorization is available in my case because some public hospital I don't have. And in generally, posterolateral approach imply in remove the posterior arch of the occipital bone. In most of the times, you can preserve the condyle. I used to do a craniotomy of the posterior fossa and laminoplasty of C1. After that, you open the dura, and I visualize the vertebral artery first here, and after that, open the dura, you can see the tumor. See, even anteriorly, posterolaterally, is the tumor appear immediately because this displaces the amygdala from up. It displaces the brainstem for the other side, and you can remove it with the traditional microsurgery techniques. Look, the first case I put in the prone position, start the incision, and the vertex of the mastoid tip, cross little bit the transverse sinus until the other side, and descend until C2 and C3. Look, is the tumor. Why I did the far lateral approach in this case? Look, you see here is the bone prominent. It's a hyperostotic reaction here, and I need to drill some bone. When I need to drill some bone from the condyle, I need to see the vertebral artery. And sometimes with this, the vertebral artery is covered, mainly V3 covered by this bone. And then I drilling, and I could to have a large approach to the tumor, displace the brainstem here, the first and second cervical raises, and I could to remove all the tumor without any neurological deficit, as you can see here, piecemeal, and all the structures is preserved here, okay? Look at the nerves, the vertebral artery here, and the first and second segments, and here the postoperative view. And then, until now, I use the far lateral approach. Look at this case. This case is, I don't know if the tumor is the foramen magnum tumor, is the clival tumor. For me, is the clival tumor, middle place, totally anterior, but I did a extended far lateral approach and go up until dissect all the sigmoid sinus and jugular foramen bulb. And you can see here, I need to drill the condyle and extend it with the retrosigmoid approach. As you can see here, the size of the craniotomy, dissect all the vertebral artery. And in this case, I needed to look at the bifurcation, the carotid artery. I needed to dissect all the vertebral artery, look at the raising of C2. The C2 raising is a reference for external V2. And here you can see the vertebral artery again. You can see all the sigmoid sinus. I skeletonized all the sigmoid sinus in order to have an anterior control of the sigmoid sinus and the jugular bulb. And then I could look again, mobilize the vertebral artery to enter in this area and remove all the tumor without any neurological death. For me, I use the foramen magnum approach, so far foramen magnum approach with the transcondylar approach, but immobilization of the vertebral artery because the tumor is a little bit higher, although maybe is a more than Cribus tumor than foramen magnum tumor. But the suboccipital subtonsillar approach is very easy. And why we did and we performed a subtonsillar approach? I saw many surgeons from Professor Sami, from Professor Tatajiba, and they use it for anterior, for anterolateral, for posterolateral tumor, use the same approach as midline approach as they use it to treat a Arnold-Chiari malformation. Look, the tumor is placed is little bit anteriorly tumor. Look here, but the tumor, you can see this point, the tumor does not growing above the bulbopontinous sulcus. And then we could to remove all the tumor to the midline approach. This fact caught my attention. Logically, is the classical meningioma spinal cranial, which means more than into the spinal cervical canal, in posterolateral to the brainstem, and it's more easy to go to the midline. You don't need to go so far. You don't need to go open the posterior cranial fossa, only drilling the posterior border, the foramen magnum, and do a laminectomy of C1 and C2 and remove all the tumor without any problems. Like here, as you can see, with a simple laminectomy and drilling the border of the foramen magnum. But is this a meningioma spinal cranium? There is no doubt about the best approach for the tumors. But studied many cases. I and my friend Roberto Leal is a fantastic skull-based neurosurgeon who lives in Belo Horizonte, 1 hour from Rio de Janeiro. We used to stay together to discuss cases, to do some surgeries, to publish it together. And we discussed the Tatajiba and Sami preference for subtonsillar approach for foramen magnum meningioma, and how study many cases from the Professor Sami, many cases from Tatajiba, and review some cases, some posterolateral cases when I did the subtonsillar approach. And look, we see, we found the coincidence in all the tumor from Professor Sami and Professor Tatajiba. All the tumor operated to the midline incision like Arnold-Chiari surgery doesn't growing above the bulbopontinous sulcus. And then we propose a new classification for new classification over the Cushing classification. And then considering spinal cranial tumor is the same up to foramen magnum, up to foramen magnum. He divided the craniospinal tumor in two types. One, up to the pontomedullaris sulcus, the so-called bulbopontinous sulcus. And the other, type 2, above the pontomedullaris sulcus, means the tumor growing above the pontomedullaris sulcus, probably reach above the lower cranial nerves and above until the nerve from the CP angle. And then we classify the new classification involved spinal cranial tumors up to foramen magnum and divided the two types of craniospinal tumor, type 1 and type 2. Type 1, look, spinal cranial. In craniospinal type 1, we can do it certainly suboccipital subtonsillar approach without any problems, In craniospinal type 2, we use a traditional far lateral and or transcondylar approach because this tumor growing above the pontomedullaris sulcus. Let's see some example. Look, the tumor is totally anterior, displace the amygdala to the other side above. Look here, the tumor totally anterior. There are small expansion to the one side. Look amygdala here. And then we did a midline approach, but you can do a traditional incision. The problem is if you don't need to go so far, you don't need to go dissect the vertebral artery, dissect the vertebral artery from spinal canal, dissect the vertebral artery before the piercing, or dissect the vertebral artery between V1 and V2. And then subtonsillar approach is a medium approach. Look, as soon open the dura, you can see the tumor. Open the arachnoid sheet. Here is the tumor. The non-dominant artery is inside the tumor. I could dissect all the tumor. As you can see here, you can pass more fast. Piecemeal. Sometimes I use a ultrasound, but nobody. Ultrasound is disposable in public hospital. In general, is broken. A lot of things. If you can grace, if you wait, all the things working perfectly. Look here, the vertebral artery dissected from the nerve. Remove the rest of the tumor. Look, the tumor was totally resected there. Look at this. Lower cranial nerves, hypoglossal nerves, vertebral artery, spinal accessory nerves above, and the tumor were totally removed without any neurological depth. As you can see the pictures, look again here, look at the vertebral artery, pica. Here you see the lower cranial nerve, hypoglossal nerve, and non-dominant vertebral artery on the side of the tumor. As you can see, the different steps from the resection of the tumor. And again, all the nerves dissected without any neurological problems. And here again, look at this lower cranial nerve, hypoglossal nerve, and vertebral artery, non-dominant artery. And here, the spinal accessory nerve. And the postoperative view. I could to dissect the non-dominant artery is here. Look, is the pica, and the tumor were totally resected and the lady didn't have any problem. But there are some nuances. Look at this tumor. I could to see the vertebral artery in these different types of MIR images. And then I plan, is the tumor anteriorly, below the bulbopontinous sulcus, but I could to see the dominant vertebral artery. Put the patient is in the public hospital. Look, there is no monitorization. I never flex the neck so much because if you flex the neck so much, you can compress the tumor against the brainstem. I use a test. I used to put the patient sit on the bed and flex the neck during some minutes. And if doesn't have a problem, I can go to the surgery more calm, more quiet, because I can move more the neck. But sometimes the patient became dizziness or something like that, and then I have a limit to flex the neck at the surgery. Look, the patient is a young lady, is a young girl. Look at this. The same incision for lateral approach, the bone. Here, look at the image after remove the bone. Here, I started to dissect the vertebral artery. Here is the condyle. Here, I try to dissect the vertebral artery and the spinal canal and the junction and the cerebellar fossa. And after dura, look at the tumor, the spinal with the small branches, Here you can see the vertebral artery piercing the dura, the tumor, and the amygdala, and the brainstem, and after remove totally the tumor in the public hospital without the monitorization and without the CUSA. Look at this. The condyle, I drilled so much the condyle, but patient doesn't develop any instability problem. And then you can see here, after surgery, the MIR without any tumor. And my last case I did 2 weeks ago is the old lady. The old lady doesn't have a posterior arch of C1. And the posterior arch of C1 there is a remaining fibrous band, but it's a very calcified fiber band. Look, see, is the tumor is spinal cranial tumor. Logical I can do a traditional midline approach, but I look at here, the vertebral artery, and the tumor displaces the bulbopontinous junction to the other side, and you can see here, dominant arch of C1 is a very important. Why is very important? We have a oral X-ray of the spinal canal or CT with the bone windows for this anomaly. Can you imagine to cut the muscle and until the dura? Oh, will be a disaster. Look at the band calcification, very large band calcification, like a tumor that. And then I could to dissect all the tumor, look at the spinal cranial nerve, spinal nerves, C1 and C2, the brainstem here, Look at this branch came from to the 11th nerve, accessory nerve, piecemeal resection, and the tumor were totally removed. I cannot remove the dura in front of the tumor. I coagulate and I follow this patient and leave the dura, doesn't have a problem for me. Problem is to remove because the bleeding, the extra dural bleeding here is a very difficult too. This is my series here in the mainly maybe completed by 6 or 7 patients. We have a complication, and I call attention for gastrostomy and tracheostomy. If you think in tracheostomy and gastrostomy, please do it. Save the life, and the patient recover very well the dysfunction. Because sometimes if the tumor involved the lower cranial nerve, a simple dissection can cause a neuroplaxy, and if you do a tracheostomy and gastrostomy, you save the life and the patient recover the function very well. Only one of my cases was late mortality due to a typical meningioma who recurs for many parts of the nervous system. That's my message. I know my friends don't need the message, but is a resume of my paper. Thank you for all.
Thank you very much, Jose, for this wonderful presentation and nice selection of cases. Any questions to Jose Landero?
May I mention something?
Yeah. Go ahead.
Thanks, Prof. Landero. This was a great talk. And generally, the subtonsillar approach for foramen magnum is not a well practiced, but I have to be honest. I'm sort of converted after your talk, and this is something which is really very, very useful because the angle of attack will be towards the base, and in cases where, especially tumors invading into the hypoglossal canal, which you've shown in your beautiful slide, this is exactly where you could probably get some of this tissue or tumor within that canals, because that's the angle of view you have. And recently, we had a similar discussion with the Prof. Luciano in Verona. Prof. Strategy was talking about it. Thank you.
Thank you. You talk about the hypoglossal canal, né? Is a limit for drilling the conline, no? Yes. Professor, I confess to you, it's very difficult to me to imagine how to stop the drilling the condyle. Because the people said, look to the jugular tuberculum, and then is the limit to stop to drilling the condyle. But I don't believe this. And then I use a simple maneuver. I open the dura and try to look inside. Sometimes it's difficult, but I try to look inside, mobilize the tumor to try to imagine the hypogloss. I remember one letter, and we talk about in Rio de Janeiro, and you talk about this. But for me, it's very difficult to stop. I never have an accident. Sometimes I stop below, before to enter in the condyle, but it's very difficult to me idealize this area. And I don't know if neuronavigation help to found this structure. Can you have experience with this?
Yeah, so my question actually was slightly different. I thought the subtonsillar approach is a very good approach to see that canal and the tumor invading into the canal from that angled view, which gives you a good exposure. So I'm just commenting on the appropriateness of the subtonsillar approach. I think it's a great approach. Thank you.
Thank you.
Any other questions? Well, I think we are a little bit tight with the time, isn't it, Professor Ramesh?
Yes, I agree. I think we are overrunning because Prof. Proji and Prof. K.K. Turel also are in desperate need to go. needs to catch a flight as well. Roger wants to leave as well.
So we have to give the priority because of the flight for Professor Keki to present his presentation, skull base, past, present, and future. This time complication will come secondary. Keki.
Yes.
Professor Keki.
He has not zoomed out. He is not. Can you hear me? But they're not.
Yes, we can hear you.
The previous presentation has not moved out.
Unable to share.
I'm unable to share.
You're unable to share. Maybe, Lantero, have you unshared your talk?
He has not unshared. Lantero is to unshare.
Let me see. Stop share.
Yeah.
Here.
Now you are unshared. Yeah.
Oh, sorry.
Yeah. Okay.
Keki.
All right.
You're
Okay.
on.
Okay. Yeah. Can you see my first slide?
Yes. Go ahead.
Okay. Thank you. Thank you very much, Ramesh Imad, for this wonderful opportunity and for your continuing activity on this IANA. I want to talk about past, present, and future, but I'll just quickly rush through it because it's a very limited time. Only the man who knows exactly the art and science of the past and present is competent to aid in its progress in the future. Something that Bildrod said more than a century ago. So, skull-base surgery did not emerge suddenly. It was a coalescence of pioneering individuals, several specialties over several decades, each new development a precursor to future advances. As is said, we stand on the shoulders of the giants. So several bricks contribute to building a wall, that ever-increasing height of which is akin to the world's tallest towers, with a deep and broad base. In spite of changes in time from past to future, irrespective of instrumentation and modernization, so let's remember that for safe and successful practice for surgery of the skull base is knowledge of anatomy. Should have changed. Skull-base surgery has evolved from huge to moderately open transcranial approaches to image-guided, minimally invasive and endoscopic procedures. As in the past, the future is being continuously shaped by advances in visualization, instrumentation, and interdisciplinary collaboration. The focus ahead, therefore, is precision, safety, personalization, and digital visualization. So, evolution of the skull-base surgery in the first phase is the past, when microsurgery, neuronavigation, and early endoscopy took place, followed by intranasal approaches and all these things that I have mentioned here. So I'll quickly come straight away to the past. Introduction of operating microscope, which I was introduced to in the late 70s. And you can see me here operating more than 40 years ago with a very primitive Optimus 1 microscope. That same era also saw the development of neuronavigation, and in 2000s, we had the beginning of image-guided cranial surgery, which helps us to correlate anatomy with preoperative imaging. Then endoscope was introduced the first time in India at our hospital in Mumbai more than 40 years ago. Later on, endoscopic tools emerged, and then came the concept of minimally invasive corridors, which actually laid the foundation of modern skull-base surgery. And I must pay tribute to my dear friend, Axel Pranetsky, who really revolutionized the idea of minimally invasive surgery, and with whom I conducted one workshop in Esquelab Academy many years ago. So, endonasal approaches, there was a major shift in endoscopic, allowing access to surgeons to go all along from anterior to posterior corridors in the anterior skull base, so that we could approach from the smallest pituitary microadenoma to vastly invasive clival chordomas. Of course, endoscopy continued to advance with high-definition tools being available, and this revolutionized skull-base access with multi-corridors and hybrid approaches, reducing morbidity and getting better cosmetic results. We go to the future in these 2020s now, with all these things, which I'm going to quickly run through. Advanced visualization, we know what MRI and CT gave us real-time assessment of tumor removal and navigation accuracy. These innovations marked the beginning of truly minimally invasive skull-based surgery. Exoscopes came later on with 3D visualization. The most important thing is they improved the ergonomics, allowing surgeons to operate long hours with clarity and a teaching capability. We had the distinct advantage of enhanced magnification, ergonomics, as I said, and it had a vast 3D view on large displays, allowing us a teaching potential. So you can see in this image a standard view on the left-hand side, where you can see identification of the facial nerve, where the sucker is there. But once you have a better definition, you can identify it so much better. So this exceptional anatomical clarity was given by the 4K and 8K visualization in skull-based surgery. DTI and vascular overlays together helps to safety dissect deep and eloquent areas of the skull base. Tumor delineation was further enhanced by 5-ALA, which enables clear visualization of blood vessels, and this combination enhancing additional overall patient safety. It's not only useful for gliomas, but also for meningiomas and schwannomas, utilizing sodium fluorescence, also ICG and 5-ALA. Augmented reality actually means it enhances or augments our perception of reality. And how it does it? By overlaying digital information like graphics, sounds, and text onto the real world in real time. Virtual reality, on the other hand, is actually virtual, not real. It exists virtually, doesn't exist physically. So here you see AR navigation. Our classic example is real-time visual guidance by navigation, which we are doing every day. So VR, virtual and augmented reality, allowed us to practice on the VR, allowed us to practice on patient-specific 3D models even before we enter the operating room. And real-time augmented reality overlays during surgery, improving accuracy and safety. So virtual reality simulators, now we have an environment where trainees can practice brain or spine surgeries without really seeing a real patient. And additionally, it has the advantage of haptic feedback models, which adds realistic touch and assistance. So together, VR with haptic allows surgeons to see, feel, and practice complex neurosurgical procedures, building confidence and skill before entering the operating room. Robotics have now come in, and the future of the skull-based surgery is going to be defined by digital integration and personalized precision through robotic systems. What it does is enhances dexterity, and AI supports preoperative planning, real-time navigation, and outcome predictions. With fully integrated digital ORs, we are having imaging, AR guidance, data analytics to optimize every surgical step. We heard Ayub Shadin talk something about that as well. And we also have molecular profiling and targeted therapies, which is going to reshape treatment strategies. So robotics can be of 3 different types. Tremors, it first of all allows you tremor-free precision, allowing to perform delicate maneuvers safely in narrow and deep skull-based corridors, enhancing dexterity and allowing us to enhance integration with imaging, thereby enhancing the accuracy and reducing the surgical risks. We have passive robots, which means they're completely controlled by the surgeon. We have active robots, which does the task completely independently. But most of us use semi-autonomous robots, which is called ROSA, which allows surgeon to retain partial control, like in stereotactic surgery. So we have artificial intelligence, and skull-based surgery allows preoperative planning, analyzing image data, and we have image segmentation, which means algorithms automatically delineate tumors, vessels, and critical structures. And we have intraoperative decision support, real-time guidance, and predictive analytics, make data-driven decision during surgery. So artificial intelligence really is a multidisciplinary science focused on developing computer systems able to perform tasks that ordinarily require human intelligence. AI branches into machine learning and deep learning. Both the things, machine learning means using to identify and select features by which the algorithm learns to complete a task, whereas deep learning is a subset of machine learning, but the features are not pre-specified, and classification tasks from the data without human intervention. So machine learning in skull-based surgery allows us to analyze data to predict surgical risks. By evaluating historical surgical data, AI models provide estimates of expected functional and oncological outcomes. And these enable tailored strategies. That means we call it personalized surgical planning. So real-time registration align preoperative 3D imaging with patient's anatomy during surgery. And we have dynamic updates which track surgical instrumentation whilst the procedure is on, and workflow optimization, that means allowing automation, reducing manual adjustments. So AI-driven skull-based assessment enables us to objectively evaluate accelerating master of skull-based techniques through data-guided learning, as you see over here in this slide. We have smart operating rooms in skull-based surgery today, which gives us continuous intraoperative anatomical guidance. Many years ago, I had visited Scott Theatre in Tokyo University on the top and right-hand side. You can see me practicing this. And you have on the walls all the panels which allow us to see everything that we need to know as we are operating. So it improves patient safety, particularly in complex skull-based surgery. So these theaters are going to integrate real-time imaging, robotic assistance, AI, AR, thereby creating a synchronized surgical environment. This enhances intraoperative decision-making and makes our surgery extremely precise. And so there is a seamless instrument tracking, automatic workflow optimization, real-time tracking, optical or electromagnetic, AI-powered workflow recognition, allowing these AI algorithms detecting the stage of surgery and preparing us or predicting the next step and preparing relevant tools or imaging automatically. We have integrated OR platforms, what we call as digital ecosystem. That means all the devices are connected via a unified platform and automatic data fusion, instrument positioning overlaid on live CT, MRI, AR anatomy, and exoscope screen. We also have safety alerts and automatic checks, which gives you real-time warnings, and workflow optimization, which makes the whole thing very automatic. There are smart instrument tables now and inventory systems, which gives us surgical trays are digitized, scanned, and it gives us a barcode. Therefore, the OR actually knows which tools are in use and predicts the next step requirement. So real-time updates during surgery, dynamic adjustment of surgical times, and enhancing precision, giving us a continuous imaging update. We have portable equipment now. CT scanners are already in market, as you know, for all these things. And more recently, we have this hyperfine swoop system, portable MRI, which is 0.0262 portable MR technology, which can be moved into the ICU to image patients effectively without requiring any non-magnetic equipment. Molecular and genetic targeting tumor genetics are available from tailored surgical adjuvant therapy. There are biomarkers which predict aggressiveness, integration with precision medicine, and collaboration with molecular neuropathology. And Raman spectroscopy, as you know, discriminates normal brain tissue from a brain neoplasm, and this would guide for decision-making and surgical dissection. Raman spectroscopy comes from the name of the scientist, Indian scientist called Raman, and he designed his non-optical, non-destructive, non-invasive technique where it is based on inelastic scattering of light by vibrating molecules, which demonstrates, therefore, it discriminates normal brain tissue from brain neoplasms. Recently, I had the opportunity of visiting this equipment in the last week in Philippines, and this is called confocal laser endomicroscopy, CLE, where you can see the instrument rests on the tumor tissue, and this is scanned, and this scanned information is sent by a machine learning through to the to the pathologist wherever he is located in the same hospital, or it can be another country or another continent, and he can then go to digital biopsies in real time. And it's extremely helpful in cancer surgery when you're taking a biopsy and immediately you get an answer. There's no need for anybody to take a physical frozen biopsy. It's all there, which can be screened and sent across to the lab. And this is particularly useful to identify low-grade gliomas from the surrounding brain, glioblastomas, pituitary adenomas, and so on. So this is a new thing which is called CLE, and this is marketed now by a Korean company. So applications of molecular medicine now, from generic chemotherapies to targeted approaches. So we have tailoring both surgical strategy and adjuvant therapy, identifying aggressive subtypes of tumors, guiding the extent of resection, and it reduces recurrence risks and supports more precise patient-specific management. So molecular and AI-driven skull-based surgery helps assist us by machine learning, automation potential, tumor genetics, biomarkers, integration with precision medicine. We now have stem cells technology, which may promote more complete resection of some skull-based tumors. We know all about skull-based, all about stem cells already, so there's no need to go through, but we are seeing an increased application of induced mesenchymal pluripotent stem cells and perinatal cells. 3D printing and reconstruction has already been readily available for a long time. There are customized implants which perfectly match defects. Dural substitutes are now increasingly available in the market by different companies, and they replace and reinforce damaged dura, giving us watertight dural closures. So together, these innovations improve post-operative healing, reduce complications, and support functional recovery in complex skull-based reconstruction. Another great arena is bioprinting for vascularized bone and cartilage, and these graphs matching patient-specific skull-based effects are a new dimension that we can have from tissue engineering departments, integration, healing, and long-term durability. This technology could enable full biological reconstruction of skull-based effects with improved function and reduced rejection. We now have multidisciplinary collaboration. It brings together specialists from our allied specialties, from neurosurgery, ENT, radiology, where we can share experience and coordinate decision-making. We have swift corridor selection, optimal reconstruction, and real-time problem solving, which we can practice even before surgery and during surgery. Training and simulation. Now surgeons can gain exposure to diverse perspectives, tools, and real-world problem solving alongside peers and experts from related fields. So we have interdisciplinary learning, shared simulation and workshops. All this is now really happening in real-time mentorship and teleguidance. So telementoring and remote supervision using AR has now become common, enables real-time guidance across continents, expanding expert access to complete skull-based training. So we have accessible to surgeons in all regions, strategies to promote democratization of education and high-quality training worldwide. We have ethical and training implications, balancing automation with surgical judgment, all this data privacy, AI algorithm transparency, and maintaining human skill in an AI-augmented era. So global accessibility is open source surgical simulation software, freely accessible, non-commercial digital platforms, which is available universally where people can practice surgical procedures virtually, cost-free access, customizable modules, global knowledge sharing, and safe skill development, which is open source, enables universal access to training in complex skull-based approaches, independent of institutional resources. So the aim is to have equal access to advanced skull-based surgery and skull-based care worldwide. So I would conclude that for thousands of years, surgery was about the hands, about steady hands, skilled hands, hands that could cut and sew, hands that could carry both precision and courage. Watch a surgeon work, and it's easy to think the magic lives in the hands. The scalpel, the steady movements, the elegant choreography. of tissue and steel. That's the part people can see. Yes, surgery has always been about more than mechanics. Here's the quiet truth. Surgery is a cognitive task, implemented through hands. The real surgery starts long before the incision, whether you use technology or your own brain. It's about judgment. It's about knowing when to intervene, how much to risk, and when to stop. It's about blending science with artistry, precision with restraint. It lives in the decision-making, the choice of how to approach, when to pivot, and when not to operate at all. It lives in the judgment. That can't be taught by an algorithm. That responsibility, that can't be delegated to a machine. A surgeon just doesn't cut. He thinks and then acts. The distinction matters more now than ever before, because the buzz around the future of surgery is now filled with talk of technology, sharper robots, smaller incisions, more precise instruments, all that can map, predict, assist, and maybe someday replace. But robots don't decide what matters. AI doesn't hold the weight of telling a family why surgery is or isn't the right path. Technology may shape the tools, but judgment will always shape the outcome. So surgery is a deeply human act, not just because it's done to human bodies, but because it's guided by human minds. What will define great surgeons in decades to come, it won't be how fast they can suture or how flawlessly they can operate a robot. It will be how cleanly they can think, how clearly they can think, how wisely they can decide when to or not to operate at all. This shift has consequences. If surgery is fundamentally cognitive, then training can't just be about time in the OR. It must teach clinical reasoning, pattern recognition, anticipation, restraint. It must teach how to be accountable for decisions that no machine can learn or teach. In times to come, yes, the tools will evolve. Technology will take us places we couldn't have even dreamed of a generation ago. But the core of surgery is not the tool, it is the surgeon. And if we lose sight of that, we risk building a future of surgery that is efficient but hollow, precise but soulless, which is technically perfect but devoid of judgment. So the future of surgery isn't just in steadier hands, it's in sharper minds. Because in the end, robots can't hold a scalpel, but only a surgeon can hold responsibility. So you must remember wisdom versus innovation in neurosurgery. Technology is advancing faster than many can follow. Younger generation adapts quickly, but familiarity is not the same as mastery. True discernment is separating benefit for patient versus novelty. Experience of our 30, 40 years gives irreplaceable wisdom. Therefore, balance is needed. Wisdom of the age plus fluency of youth. Thank you very much.
Thank you very much, Keki, for this wonderful presentation. You cover it all. I have to tell you, AI, we won't let AI replace Keki Turrell, humanity, judgment, and charisma. I think we can take one or two questions. Who had any question to Keki's presentation?
We just wanted to say, Teki, that was a very powerful talk and a powerful message at the end. A lot of wisdom in your talk about the upcoming future. Nobody can replace the surgeons because it's the thinking process that behind the decisions we make, not exactly the precise surgery we do. Everything makes I also have the same opinion. I don't think talk about robots replacing and AI replacing surgeon, but it's very unlikely, at least in the long future. Thank you for this powerful talk.
Thank you very much. Thank you.
Thanks, Keki.
Okay. May I be allowed to leave if you don't mind? I have a
Okay. All right. So we'll move to the next speakers. We'll give it an attempt. Also, Bredji, if you are ready for your presentation on iBuy approach, advantage and limitation, and see if it can work. Professor Giovanni.
Let's see if it's working now.
Yeah, okay.
Okay.
Go ahead.
Okay. Jesus. I get in trouble with okay.
Yeah.
Let's see. Did you see the
we cannot-
presentation?
Not
No,
yet.
you haven't started
No.
sharing yet. Maybe it's a Mac. I think that sometimes can cause a conflict.
Okay.
But if you see the
Listen.
share button,
No, let's forget, and I will arrange for the next webinar of.
We'll keep you for
sorry
the
for
next
that.
webinar. No problem.
Okay.
Support you.
Ciao, ciao.
Okay, ciao. I'll invite then Professor Gungwa Abuzer to present as the finalist, but not the least, it's a very important subject, vein preservation technique in neurosurgery. I just want to give one word to give salute and appreciation to Professor Akira Hakuba, who initiated the subject very strongly by initiating a society on cerebral veins and meningioma more than 25 years ago, and it tends to be very essential. Professor Abuzer, go ahead with your presentation.
Can you hear me?
Okay, you are on.
Okay.
we can hear you, yes.
And could you
Yeah.
see
We
my
can see the presentation, yeah.
Okay, okay. I will talk about the vein preserving techniques which I used in my operation, and what is the best strategy to prioritize the vein preservation, to know there's no room for sacrificing veins, because we know sacrificing veins, you can face any kind of complications, even death. Mostly the cerebellopontine angle approach, the petrosal vein is sacrificed, but you can face with any kind of complications. And also in hemispheric approach, if you sacrifice veins, you can face with the complications like edema, like paralysis, and also patient need additional operations for venous infarcts. And which techniques I use, for example, this is the sphenoid wing meningioma. Even I preserve the meningoorbital band because, as I will show, this also I did a clinoidectomy, but opening the dura, you would see the cortical vein, which veins directly goes to the meningoorbital band. And also in any kind of operations, for example, this is the MCA, incidental MCA aneurysms. After opening the sylvian, you can see there's a aneurysm located in the MCA bifurcation, and there's a vein attached to the aneurysm neck. You must dissect the this vein to clip to preserve the vein. After the attaching the vein from the neck of the aneurysm, you can clip. You can use sharp dissections, also blunt dissections. After the attaching the vein, you can clip the aneurysms. As you know, the mostly used approach is the pterygium approach, but sometimes the sylvian veins can go directly to the dura, and to preserve the veins, you can cut the dura with preserving the veins, and also you can cut the one layer of the dura to release the vein from the dura, and also you can open the arachnoid above the vein to release the veins. Sometimes to preserve the veins, you can leave some remnant tumors. And also in interhemispheric approach, this is the from the paper which I showed before. If they face with an bridging vein at the midline, mid part of the craniotomy, they sacrificed, but they reported some kind of complications. If we face in this kind of bridging veins, we cut the dura with preserving the venous drainage. And also in interhemispheric approach, before the operation, we examine the all contrast enhanced MRIs and MR venography to select our craniotomy site to preserve the bridging veins. For example, this is a colloids. We open the dura. You can see our craniotomy site and the two bridging veins. And also, you can release the veins to open the arachnoid above the veins. And remove the kyst, and this is the postoperative view. Sorry. This is a thalamus tumor, and at the midline of the our duotomy, we couldn't detach the vein from the dura. Then we decided our entry point. Then with Doppler ultrasound, we detect its drainage, and we decided to approach from the posterior part of our duotomy. And remove the tumor. And this is the postoperative view. As you see, we cut the dura with preserving the bridging vein. And also there's another case which we preserved the bridging veins with performing our surgery from both sides. And also in suboccipital approach, the occipital vein mostly sacrificed, but with sacrificing if it is dominant, you can face with a complication, the cerebellar edema and venous infarction. Because of this, we develop a paramedian linear incision to preserve the occipital sinus and the marginal sinus. And also you can combine with the other incision to extend your approach. These are some cases which we use these paramedian linear incision with preserving the occipital sinus. This is previously operated with the thalamus tumor, but the patients came after 2 years with the brainstem tumor. As you see, this is the occipital sinus. We made a linear incision just lateral to the midline with preserving the occipital sinus, and remove the tumor. As you see, also, if you open a linear incision, it is easy to close. This is the postoperative view. And also there is a fourth ventricular tumor. We use a median linear incision to preserve the occipital sinus. And also with small incision, you can remove this kind of tumor. Also in supracerebellar approach, the bridging veins is a challenging issue. And you can you can dissect from the cerebellar surface and the temporal surface to preserve these veins. After opening the dura, as you see, there is a bridging veins, and we are trying to dissect from the cerebellar surface, open its arachnoid, and also from the temporal surface to release the vein. And also there's another case. We are dissecting the vein and remove the brainstem cavernoma. And also the thalamic cavernoma. After opening the dura, we take a bridging vein and we dissect from the cerebellar surface, also its branch, and also we put a surge cell to support the vein and remove the cavernoma. And this is the post-operative view with preserving the bridging veins. And also with Professor Ture, we develop a technique to preserve these bridging veins in supracerebellar approach. We cut the tentorium with preserving its drainage. You can release the veins. This is the cadaveric view. As you see, you can see the bridging vein and its drainage. And after cutting the tentorium, it will be released and you can continue your operation. This is one of my case, the mesial temporal lesion. There is a vein I couldn't release with the dissecting from the tentorium and the cerebellar surface, and decided to cut the tentorium to release the vein. How we can detect its drainage? You can also you can see with microscope, and also you can use Doppler ultrasound, and also with ICG you can see the its drainage, and with preserving its drainage you can cut through and release the vein. And also in retrosigmoid approach, as you see, the sacrificing the petrosal vein is very common, but as you see, the petrosal sinus drainage coming from the old brainstem, cerebellum, anterior and superior surface. Because of this, it is important to preserve this vein. This is a retrosigmoid approach. After opening, you can see the artery attached to the dura. Firstly, they attach the artery to preserve. Then also you can see the petrosal vein. We will attach to form its arachnoid and dissect, and we'll continue our operation. As you see, when you dissect the veins, you can have enough view. This is the before the dissection and after dissection. And also in tumors, or especially in the related with the middle fossa and other tumors, it is sometimes it can be attached to the veins. As you see, with attaching the all tumors from the veins, you can preserve. And also the preoperative the virtual reality applications is suitable to detect any veins. And as you see, this is a brainstem tumor. As you see, with this augmented reality image with 3D models, we can see the bridging veins. And in the operation, you can see these bridging veins. As you see, always it takes times. There's a lot of branches of the petrosal vein. But I couldn't have enough space to reach the tumor. Because of this, I opened the transverse fissure, transverse flux of the cerebellum. This is the post-operative view after removing the tumor with preserving all veins. It is my view as a young neurosurgeon. I am waiting the expert opinions from all lecturers. Thank you for listening.
Thank you very much, Professor Abuzer, for this wonderful presentation. I adapted some of your technique as well on the approach to the pineal gland. I like this manchet of dura to be mobilized with the vein. Wonderful technique. Thank you. You give a wide spectrum of possibility at different sites. We open for some questions, 1 or 2 questions, please. Any questions?
Victor has a question.
Professor Victor?
Congrats, Professor Abuzer Gongor. Really nice dissections of the veins. I think this is very important to avoid cerebral infarctions. In the case of the temporal lobe veins, it's very useful to understand anatomical variations. For example, vein of Lavey exhibits too many variability in its drainage. In some cases, we have a presence of accessory venous channels. So it's not only important to preserve the main vein, it's important to know the accessory venous channels. What do you think about that?
Sure. It is very important to preserve not only veins and it is drainage, like as I showed in the in our supracerebellar approach. It is not enough to preserve the veins while cutting the tentorium. Also, you must preserve it is drainage to the from the entering the tentorium to the sinus. Yes, you are correct. It is always important not only preserve the vein, and it is drainage from the dural or from the sinus.
Thanks. Congrats.
Any other questions?
I just wanted to thank you. Thanks, Abuzer. Such a great talk and such an important message as well for everyone. It's wonderful to see you. First of all, your videos were really great. But also, it's wonderful to see the extra effort you're taking to preserve the venous channels. And many of us probably wouldn't think twice, especially the supracerebellar approach. Unless they are the main veins, we normally try to preserve some of this draining vein. We will try and, if it is coming in the way, we might sacrifice it. But one message so powerful is that you're taking such a extra care to keep them, which also will improve the precision and the accuracy of operation, which is so an important message for including the trainees. And you mentioned about strengthening because often we try to preserve it, but during the operation, we sometimes put undue stretch on these veins without realizing it, and they start to bleed, and you have to coagulate it. that happens with the petrosal vein or happens with the tendorial veins. You mentioned about putting some surgical around where it is joints, that might help. But also I suspect that the fact that you try to resect the dura around it and also maybe peel off the arachnoid at the cerebellar side will give you some extra laxity, so that even if you put little bit more stretch, it will still be preserved. So that I think that's quite a good technique. Thank you.
Thank you.
Any other questions?
Thank you.
Thank you. Before I give over to Ramesh to conclude. Oh, you have a question? Okay.
Yeah, I'd like to know with your colleague about the possibility to resuturing or do a vein bypass in case, mainly in case like to La vein, La B vein.
If any injury to veins, I never tried. Also, it is difficult to bypass than the artery bypass. But if you have no chance to preserve the veins, you can try to make a bypass, but it will be very difficult.
Thank you.
I think
I agree with you. They get thrombosed very easy.
I perform, but it is difficult for me.
Yeah.
It's best to preserve.
About not bypassing, direct anastomosis, especially in the sort of middle third veins in the parasocial area. Many textbooks, descriptions about maybe even putting a stent or reattaching the vein. But as Professor Imad Kanan said, because by the time you do that, the vein will be thrombosed, because you have to collapse the vein and it will keep thrombosed.
All right, so I want to give a message, if you allow me, Professor Ramesh, for the members. You see, there are several members on this academy, and the invitation that we send from Ramesh and myself is not dedicated only to the speakers. It's dedicated to all members, whoever can attend, because your presence give a flavor for the discussion after each presentation, and we notice it. I'd like to thank Professor Victor Hugo, who was present from the beginning. I see the name of Stefan Wolfsburg from Austria, and of course, Professor Kasper, he gave a good comment as well. So your presence is very valuable, and whenever you have a chance, please feel this invitation to all of you, not only the presenter. With this, I will give over to Ramesh to give some, I think, information for the future and to conclude the webinar. Ramesh?
Thank you. Thank you, Martha. Thank you for sharing, and thank you all the panelists and the speakers. Fantastic job. I hope this will be reviewed by the trainees, and we will be hopefully we'll have another webinar next month. Last month we had a direct participation in-person meeting in Cordoba, but we will have some more. I have sent you all the information about the upcoming in-person meetings, and great if we could meet up. But I'm hoping to do more webinars starting from next month onwards, hoping to get all your contributions as well. And with that, I think we have finished this webinar, and thanks everyone again. So hopefully we'll meet up soon.
Thank you.
I've already taken a picture of whoever we have, but we should have taken it in the beginning because we had more people.
Right.
Thank you.
Thank you. Thanks, everybody. Good to see you all. Bye-bye.
Good to see you all.